This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Our episode today is called Therapeutic Misadventures. Want to know how you might accidentally kill a patient with intubation? Want to know what drug Kafka called the only remedy against the misery of being? The compound that might have played a role in Rasputin's influence over the Romanovs? Listen to find out. Today's episode starts in the emergency department with a 42-year-old man in respiratory distress. According to the medics, he was smoking methamphetamine and developed shortness of breath. They know him well, reporting a history of schizophrenia and substance abuse. The patient is sitting bolt upright, breathing very rapidly at 40 breaths per minute. His oxygen saturation is 88% on 100% oxygen, low. He's so short of breath he can't speak. His blood pressure is as high as 190/87, as is his pulse at 120 beats per minute. He's agitated but able to follow basic commands. You have a lot of questions, but he's in no position to answer. We don't know if he has a history of lung disease like asthma or chronic bronchitis, i.e. COPD. Probably doesn't matter because he's at risk regardless. Meth causes a lot of problems, including bronchitis and congestive heart failure, which in turn causes pulmonary edema or fluid in the lungs. I do a quick physical exam focused on the findings related to respiratory distress. Obviously, a lung exam, listening for wheezing from bronchospasm caused by bronchitis, or crackles, the sound of pulmonary edema. I'd listen to the heart for a murmur. We don't know if he's an injection drug user. We do know those patients are at risk for endocarditis or bacterial infections on the heart valves, which can also result in congestive heart failure. Lastly, a quick check of his legs for swelling. His lungs have crackles bilaterally, no wheezing, no murmur, and no peripheral edema. His oxygen saturation has dropped to 84% in the few seconds it took for the exam. There's no more time for diagnosis. We have to skip right to treatment. There are two main options to treat respiratory failure. The first we've discussed many times, intubation and ventilation. The other option is non-invasive ventilation or BiPAP. Many people these days know what CPAP is. If you do, BiPAP is similar essentially but stronger. The machine blows oxygen into the lungs via a tight mask strapped to the face. Whenever possible, we start with BiPAP to avoid the risks of mechanical ventilation. It's safe and effective. There's only one caveat. The person must have a normal mental status and be able to tolerate the tight, uncomfortable mask. This agitated patient isn't the best candidate, though honestly, I'd still give it a try in the hopes of avoiding intubation. The respiratory therapist puts the mask over the patient's face and tightens the straps. The patient rips it off. She calms him down and tries it again. This time, he throws the mask across the room and attempts to get off the stretcher. Unfortunately, BiPAP isn't going to be an option here. You call for RSI, rapid sequence intubation meds. We give a sedative and a paralytic to put the patient to sleep. Once you give the meds, it takes about 60 seconds for them to work. Just as you pass the tube through his vocal cords, the monitor starts beeping like crazy and the nurse says the patient's heart rate is dropping. Before you can even react, he goes into asystole. A flat line moves across the monitor. The nurse starts CPR, you call for epinephrine. What the hell just happened? With intubation, as with any procedure, there's always a risk of complications, in this case, cardiac arrest. Once you give paralytics, the person's diaphragm doesn't work and they can't breathe. If you don't get the tube into the trachea fast enough, lack of oxygen can cause a cardiac arrest. If you put the tube in the wrong place, i.e. the esophagus, the same thing happens. Also, sedatives cause low blood pressure, which in turn can cause cardiac arrest. Anyone who's taken care of a sick patient knows the risk of rapid decompensation and cardiac arrest during this procedure is real, not theoretical. So did we just kill our patient? While acknowledging the fact that anyone can code during intubation, it shouldn't be happening in this guy. You double-check the tube, it's in the trachea where it belongs. His oxygen was low to begin with, but it didn't drop any lower during the procedure. His blood pressure and heart rate were high, so even if our intubation meds dropped the pressure, there was plenty of room to spare. What caused him to code? I have no idea. Let's admit it and keep moving forward. The intern squeezes the bag valve mask attached to the breathing tube. He's overly enthusiastic and squeezing too quickly. The respiratory therapist tells him to slow down, keeping the breaths around 12 to 15 per minute. Stacking breaths means the lungs don't have time to exhale and essentially become overinflated. On the next pulse check, you breathe a huge sigh of relief when the nurse palpates a pulse. Respiratory hooks the patient up to the ventilator, setting the respiratory rate to 15 breaths per minute, a normal value. The radiology tech shoots a portable chest x-ray. The labs are pending. The patient's heart rate slows down again, and he has another cardiac arrest, again asystole. We restart CPR and epinephrine. Following standard procedure, the intern takes the patient off the ventilator and reattaches the bag valve mask. This cannot be a coincidence. What is happening? Is it the meth he smoked? Certainly meth can be lethal, but the patient doesn't have a sympathomimetic toxidrome. Yes, his blood pressure and heart rate are high, no doubt from the drug, but not dangerously so. This isn't a stroke or an intracranial hemorrhage, and he's not having a lethal arrhythmia like VFib. The X-ray confirms your physical exam findings. The patient has pulmonary edema or fluid in the lungs. This could be from meth. Heart failure, as I mentioned, is one cause. Non-cardiogenic causes include lung injury and inflammation. Regardless of the etiology, fluid in the lungs instead of air leads to hypoxia. Intubation is a mainstay of treatment. He should have improved, not coded. I'm not convinced meth is the immediate cause of this cardiac arrest. If you're paying attention, you've noticed he's arresting when we put him on the ventilator. This is actually a huge clue, and I'd do a little test here. I'd tell the intern to increase the rate at which he's squeezing the bag, to take it all the way up to the patient's respiratory rate before we intubated him. Realistically, 40 breaths per minute might be tough, but at least up to 30. The respiratory therapist objects, given this is clearly outside of standard practice. But it works. The patient gets a pulse back again. This time, when you put him on the ventilator, you insist on a rate of at least 30 in addition to a large tidal volume, the medical word for big, deep breaths. You hold your own breath for a few seconds, waiting to see if it works. The ventilator beeps like crazy, objecting to the settings. The patient doesn't have another cardiac arrest? Excellent. Now we have to figure out the cause. In short, we have a patient with schizophrenia, pulmonary edema with hypoxia, and cardiac arrest. Question number 1. What is the next best step? A, an ABG, an arterial blood gas. B, a BNP, blood natriuretic peptide, and a measure of heart failure. C, a CAT scan of his lungs. D, a fingerstick blood glucose. The answer is A, a blood gas. All of these tests might be useful, but the blood gas is quick and easy. We take an arterial specimen from the wrist, and unlike our usual test, it takes just a few minutes to result. Blood gases measure levels of oxygen and carbon dioxide, useful to ensure the ventilator settings are correct. It also measures the pH of the blood and bicarbonate levels. The incessant beeping from the ventilator is enough to wake the dead, but so far the patient is still alive. His blood gas shows the following results: a pH of 7.35, a PO2 of 200 millimeters per mercury, a PCO2 of 28 millimeters of mercury, and a bicarb of 18 milliequivalents per liter. Let me sum it up for you if you're not used to blood gases or if you use different units. The pH of the blood is normal. The oxygen level is higher than normal because we have him on oxygen. The carbon dioxide is low, and so is the bicarb. As I said, the patient's pH is normal, so at first glance you might think he doesn't have an acid-base disturbance. Acidosis or acidemia is when there's too much acid in the blood, and alkalosis or alkalemia is too much base. However, his bicarb is low, and this is because the bicarb is buffering excessive acid. Why is the pH normal if he has extra acid? Because he has two disturbances, an acidosis and an alkalosis. They're balancing each other out for now, leaving the pH in a normal range. Once we determine the type of disturbance, the next step is to determine the source, either metabolic or respiratory. Metabolic acidosis results from diarrhea or renal disease, and of course from toxins. Remember the mnemonic cat mud piles? If you've forgotten, listen to the White Lightning episode. Metabolic alkaloses are usually from losing acids in vomit or in the urine as a side effect of diuretic medicines. Your lungs help regulate acid-base status. Carbon dioxide, when exposed to water in the body, becomes an acid. So, if you're breathing fast and exhaling carbon dioxide, you can develop a respiratory alkalosis due to things like anxiety or pneumonia. If you're breathing too slowly or not ventilating, CO2 builds up, resulting in a respiratory acidosis. You see this in asthma, opioid overdoses, and diseases like muscular dystrophy causing diaphragmatic dysfunction. As I said, our patient's CO2 level is low, resulting in a respiratory alkalosis. In summary, our patient has been breathing too fast, causing a respiratory alkalosis, and has acid in his blood, causing a metabolic acidosis. Review of the rest of his labs shows it's an anion gap acidosis, bringing us back to the unmeasured acids of the cat mud piles mnemonic. The ABG has given us the answer. This is a tough case. It's taken us a long time, but we haven't given up. In real life, we could easily miss this diagnosis. What toxin causes this classic mixed acid-base disturbance and is poisoning our patient? A. Carbon monoxide. B. Aspirin. C. Acetaminophen or Tylenol. D. Fentanyl. The answer? B. Aspirin. A mixed metabolic acidosis with a respiratory alkalosis is a classic finding in aspirin or any salicylate overdose. We confirm with the results of a salicylate level. It's 150 milligrams per deciliter. Yikes. Therapeutic levels range from 10 to 30, so this is really high. To answer our earlier question, yes, we did almost kill our patient by intubating him. More on this in a bit. Salicylates are one of, if not the oldest medicines in existence, in use for at least 3,500 years. Question number 2, where does aspirin come from? A, the willow tree. B, the yew tree. C, cinchona tree. Or D, eucalyptus. The answer is A. Willow bark is the original source of aspirin. Yew trees are poisonous, but also the source of Taxol used to treat breast cancer. Eucalyptus oil can be poisonous, but not the trees. Willow bark use is recorded as far back as the Sumerians. It's mentioned in the Ebers Papyrus from Egypt, and in ancient Greece, Hippocrates prescribed it for inflammatory pain and childbirth. Cinchona is the source of quinine to treat malaria, and interestingly associated with the modern use of salicylates in medicine. In 1758, Reverend Edward Stone was looking for a cheaper alternative to cinchona for treatment of agues or fever. This was during the Napoleonic Wars, and blockades interfered with the importation of cinchona bark from Peru, making it very expensive. He decided to try willow bark instead, showing it reduced fever in the 50 patients he treated. Salicylic acid is the active ingredient in the bark, identified in 1828. 7 years later, modern aspirin, or acetylsalicylic acid, was synthesized by Felix Hoffmann, who worked for the Bayer Company. He was motivated to find an alternative because his father, who used salicylic acid for rheumatism, had begun vomiting due to the very strong gastrointestinal side effects. Acetylsalicylic acid was easier on the stomach. Side note, Hoffmann's next success was diacetylmorphine or heroin. Once Bayer marketed the drug, its popularity exploded worldwide. Hilariously, there was initial concern for cardiac toxicity, which, though disproven, prompted a warning on the aspirin label saying, quote, does not affect the heart, quote. In a letter to his fiancée, Franz Kafka called aspirin the only remedy against the misery of being. It's mentioned in works by Thomas Mann, Henry Miller, and Gabriel Garcia Marquez. One really fascinating fact is salicylate toxicity probably increased the influence of Rasputin over the Romanovs. Tsar Nicholas II's son, Alexei, took aspirin like many during this time. Rasputin, advocating less Western and more mystical cures, told him to stop. Alexei improved. Why? Because he had hemophilia. This probably strengthened Rasputin's position within the family. So back to our patient. We need to start treating him for aspirin toxicity. We're already using the ventilator for hyperventilation. This helps keep salicylate out of his brain. I would give multi-dose activated charcoal to bind and inactivate salicylates. Why? Aspirin clumps together, forming what's called a pharmacobezoar. A bezoar is an indigestible material found in the stomach, and interestingly, bezoars from animals were believed to be an antidote for poisoning in the Middle Ages. But that's a topic for another day. A pharmacobezoar behaves like a delayed release preparation, so among other mechanisms, administering charcoal every 2 to 4 hours can bind the toxin as it's slowly released. The mainstay of treatment for salicylate poisoning is alkalinization. This serves two purposes. The first is increasing the pH of the blood, pulls salicylate out of the brain and tissues and back into the blood. Second, urine alkalization traps salicylate in the urine, allowing increased elimination from the body. How do we alkalinize? By giving bicarbonate. I'd give him a bolus dose of 1 to 2 milliequivalents per kilo, then tell the nurse to spike a bag of D5 water with 3 amps of bicarb, or 150 milliequivalents, and run it as a drip at 150 mLs per hour. The exact rate will vary, and in our patient, we need to be careful because he already has too much fluid in his lungs. You want to titrate the rate essentially to an alkaline serum pH, keeping it well above the normal 7.45, but below 7.5. The urine pH should be greater than 8. What about extracorporeal removal? Dialysis removes salicylate from the blood, so it's a great option, but it's an invasive procedure. The indications, i.e., where the benefits of dialysis outweigh the risks, are in patients with an altered mental status, a high salicylate level of 100 milligrams per deciliter, 7.2 millimoles per liter, or higher. Severe acidosis with a pH of less than 7.2, hypoxia requiring oxygen, or failure of standard treatment. Our patient meets a bunch of these. He has an altered mental status, he's hypoxic, and has a dangerously high salicylate level. You call nephrology for dialysis. If you had any doubts about intubating him earlier, I can tell you we'd be doing it now regardless of his respiratory status, for dialysis catheter placement. He was too agitated to safely tolerate the procedure. I'm sure you know about aspirin and its effects on thinning the blood, the reason we use it in heart attacks and strokes. Subacute or chronic exposure leads to well-known side effects of bleeding and gastric ulcers. In overdose, salicylates have a lot of effects. Let's discuss some of them, focusing on what happened with our patient and how we accidentally almost killed him. First, salicylates stimulate the respiratory center in the brain, causing an increased respiratory rate and increased depth of breaths. This blows off CO2, causing the respiratory alkalosis. Second, salicylate toxicity causes metabolic changes, including uncoupling of oxidative phosphorylation, resulting in energy failure at the cellular level. For more detail on this, listen to the explosive heat episode. Salicylic acid is itself an unmeasured anion, contributing to the anion gap acidosis, along with the results of energy failure, including an elevated lactating ketones. This combination acid-base disturbance gives us the classic clinical picture associated with toxicity. Of note, this finding is less common in children and in chronic toxicity. CNS toxicity due to salicylates in the brain leads to an altered mental status, cerebral edema or swelling of the brain, and ultimately seizures, coma, and death. Thus, the goals of treatment focus on keeping salicylates out of the brain. Our patient had pulmonary edema and ARDS, fluid in the lungs. This is not uncommon, though the mechanism is poorly understood. It's likely a result of vascular changes with resulting fluid accumulation. How do these effects cause cardiac arrest during intubation? Well, cells are optimized to work at normal pH levels. When the body becomes severely acidotic, they stop working properly. The classic example is diabetic ketoacidosis. When the blood sugar skyrockets, acid builds up. Before insulin existed as a drug, DKA led to certain death in type 1 diabetics. In the case of severe acidosis, if you stop the patient from breathing, you stop the body from attempting to compensate by blowing off CO2. Cardiac cells also require normal pH to function, and acidosis allows more salicylate to get into the brain. The result is immediate, and I do mean immediate, decompensation. The risk of intubation worsening the clinical status is real. Unfortunately, I've seen this occur in many cases. The first type of case is intubation before you know it's an aspirin overdose, as with our patient. The second, actually more common, is the following scenario. The patient is awake but very agitated. They have a high salicylate level and are altered, so they need dialysis. Dialysis requires a very large central line catheter to be placed into a major vein in the chest or the neck, like the internal jugular. The procedure is relatively safe if the patient lays down and holds still. If not, it's extremely easy for the needle to go into the wrong place, like the carotid artery or the lung, puncturing and collapsing it. An agitated, confused patient simply can't cooperate. The answer for this potentially life-saving procedure in a critically ill patient is sedation and intubation. If they don't get dialysis, they might die. If we intubate them to facilitate dialysis, they might die. It's truly a rock and a hard place. We try to optimize the physiology in advance. I can tell you from experience, it's always a gamble. Pre-treating with bicarb helps reduce the level of acidemia during the time the patient isn't breathing. The most experienced provider should intubate. This isn't the intern's chance. To minimize the time it takes and to ensure the tube is in the right place on the first pass. Despite these precautions, patients often deteriorate into cardiac arrest. I feel terrible we missed the initial diagnosis and almost killed our patient, as I would in real life. That said, a little perspective is helpful. A review of U.S. Poison Center data found 7 cases of intubated patients with salicylate poisoning with enough data to analyze. Of these, 2 died immediately after intubation, and a third suffered serious neurological injury, making the odds about 50-50. Our patient has acute salicylate toxicity, hard enough to diagnose without the history, as you can see. Chronic salicylate poisoning is even more difficult. It occurs typically in older adults taking high doses over days to weeks. While the presentation is similar to acute toxicity, the symptoms can be more insidious and may mimic other diseases. Question number 3. Which of the following diseases has chronic salicylism been mistaken for? A. Dementia, B. Encephalitis, C. Alcohol intoxication, D. Alcohol withdrawal. The answer? If you answered at all, you answered correctly. Chronic salicylism has been mistaken for all of those problems, in addition to delirium, sepsis, and respiratory failure, just to name a few others. Adding to the difficulty, salicylate levels correlate poorly with toxicity, and delay in diagnosis increases mortality rates to as high as 25% in some studies. Our patient is transferred to the ICU where he gets dialysis and the team monitors alkalinization, adjusting to optimize his blood and urine pH. They check serial salicylate levels, which begin to drop with treatment. In the 1950s to 1970s, salicylates were the leading cause of pediatric poisoning deaths in the U.S. The popularity of aspirin continued until the association with Reye's syndrome in children was discovered. Aspirin isn't the only form of salicylate available. Bismuth subsalicylate, or Pepto-Bismol, causes salicylate poisoning. A 12-ounce or 350 ml bottle can have as much as 3,000 milligrams of salicylate. For reference, a baby aspirin is 81 milligrams and a full-dose aspirin is 325 milligrams. So that's a lot in one bottle. The dangers of topical salicylate preparations are often underestimated. Oil of wintergreen, methyl salicylate, is a one-pill-can-kill drug. One pill can kill is a list of toxins that can be lethal in children with exposure to a single dose. Oil of wintergreen is obviously a liquid, but exposure to 1 ml or 1/5 of a teaspoon is dangerous, and depending on the concentration can have 1,400 milligrams of salicylate. Topical creams carry a similar risk. Sports muscle creams, Bengay, for example, cause salicylate toxicity. A 17-year-old girl in Long Island died after topical application of a lot of cream. Another teenager developed toxicity after using a tube of cream for masturbation. An interesting study of healthy volunteers showed exercise and heat resulted in absorption of 3 times as much salicylate than a typical exposure. Our patient wakes up and is extubated after his salicylate levels drop below 50. The fluid in his lungs resolves, and eventually we get to the bottom of what happened. The patient developed ankle pain after twisting it. Due to schizophrenia and meth use, his thinking was not clear. He ingested handfuls of aspirin over the course of a day to treat the pain without understanding the risks. He returns to his baseline mental status and has no sequelae from the therapeutic misadventures. This is a fictional case, as are all our cases, to protect the innocent, but it is based on real poisonings. Today's pop culture consult and the last question. What actor's death was attributed to an aspirin hypersensitivity reaction? A. Richard Pryor, B. John Wayne, C. Lucille Ball, or D. Bruce Lee? To note, likely misattributed. Follow our Twitter and Instagram feeds, both at PickPoison1, and you'll see the answer when I post it. Remember, never try anything on this podcast at home or anywhere else. Finally, thanks for your attention. I hope you enjoyed listening as much as I enjoyed making the podcast. It helps if you subscribe, leave reviews, and/or tell your friends. All the episodes are available on our website, pickpoison.com, Apple, Spotify, or any other location where podcasts are available. Transcripts are available on the website. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Thank you, and until next time, take care and stay safe.